Great. I think we're all set to go. It's 4 o'clock, so should we get started? So welcome everyone to this first webinar hosted by the Cornwall Training Hub. My name's Robert Sapsford. I'm a salary GP working at the Camel and Estuary practice in Wadebridge in North Cornwall. And I'm also doing a fellowship with the Cornwall Training Hub where I'm working to improve education and training opportunities for GPs. I would just like to make sure that the IT is working okay. I can see we do have some participants. Could I just ask you guys to raise your hands for us, please? So that is, you do that by, oh, perfect. Yeah, you're already starting to do it. That's great. We can see the numbers creeping up. So that's fantastic. So welcome you guys, and thank you all very much for joining us. So we're speaking to you from Cudmore House here in Truro, next to the Royal Cornwall Hospital, and I'm joined by my colleague Allison, Dr. Allison Hibbert. Hello. And I'll let her introduce herself fully in a short moment. Professor Alistair Burns, our main speaker, is joining us from Manchester, and we thank him very much for his time, making himself available to speak with us all. This is a new format of educational delivery for us at the Training Hub, and we're quite excited about it, and we want it to be as useful as possible for our attendees. So please do interact with us. Use the Q&A button at the bottom of your screen to participate and ask questions throughout. I would like to say that we are making a recording of this webinar available on our YouTube channel. So when you ask a question, if you'd like to remain anonymous, please just say anonymous at the start of your question. I won't read out your name. Otherwise, I would really appreciate it if you could tell us maybe your geographical location and your job role, and that would just really help us get a flavour of the audience that we've got with us in participation today. With that in mind, just like to say thank you for joining us and getting involved in this education opportunity. And I'd just like to hand over now to Dr. Hibbert, who will tell us why dementia has been chosen for this new webinar series.
Thanks, Rob. That's great. So yeah, I'm Dr. Allison Hibbert. I'm a GP in East Cornwall. I am also the clinical lead for NHS Kernow for dementia. Dementia is a priority for our county and has been for most of this year so far. And as I've been out and about visiting GPs and healthcare professionals across primary care, a lot of them flagged that they'd like more training in dementia and more education. It's quite hard to reach everybody across our county, and so it was great to link up with Kernow CIC to deliver webinars.
Brilliant. So I think without further ado, sir, can we ask you to maybe get us rolling with this series? And thank you very much indeed for starting us with your talk this afternoon.
Okay, thank you very much, Rob and Allison. I appreciate the opportunity to come and speak. Could it's new to me as well, so just checking if everyone can see me and hear me, and that'd be great. Any problems with that, maybe you could indicate, Rob and Allison, that things aren't going right. So what I'll do, I'll try my best to share the slides. I hope it's not working now.
Yeah.
So, yeah, I'm getting a couple of thumbs up, so that's great. So, as you say, Alison, you know, from where you've been around, there's certainly a lot of interest in dementia, so it's a good opportunity. Perhaps for me, just to summarise very briefly some of the issues around dementia from my point of view as your National Clinical Director for Dementia and Older People's Mental Health. And we'd agreed, Alison and Rob, that you could interrupt me if there are things that aren't clear, and certainly for colleagues on the phone, if there's anything that I say that isn't clear or you would like some clarification on, then please just ask and interrupt. And I think, Rob, you've established that people are well able to do that. Mm-hmm. So just a few, if you like, high-level facts and issues around dementia. I guess that many of the figures that we all know, 850,000 people living with dementia in the UK, I think it's fair to reflect that dementia is unique in that when we talk about the number of people who are affected by the illness, it's a number that you can easily multiply by 2, probably by 3, and possibly by 4 if you look at the impact on carers. And certainly much of the work we're doing in NHS England is specifically post-diagnostic support, which is for the carers of people with dementia. It's the leading cause of death. Dementia is now the leading cause of death. And if you look at the costs, it's an eye-watering 26 billion is the estimate of the cost to society. We think that possibly up to a third of new diagnoses could be prevented. And one of the things that we've tried to do over the last 2 years is to change the dialogue around dementia. It's the most feared illness in people over the age of 50, and we wanted a diagnosis of dementia to be something that opened doors rather than closed doors. I think interesting just to remind ourselves that dementia is in fact an umbrella term. It's a syndrome, it's a clinical syndrome, and in the same way that we talk about respiratory failure and heart failure, dementia is essentially brain failure. Dementia is a chronic condition. Acute brain failure we know of as delirium or a confusional state. The commonest causes of dementia are Alzheimer's disease and vascular dementia, and alone and in combination for certainly the population whom I look after, people over the age of 65, that's probably about 80% of people. There are many other conditions, and as the discussion goes on, there might be particular questions or issues about that. This is a slide borrowed from my colleague Peter Bagshaw. When we look at the progression of dementia, dementia is a progressive illness. And in fact, that's something, there's been some studies recently to show that when people are seen at the memory clinic, looking at the kind of information that they get, it's something that perhaps we as psychiatrists need to emphasize to people, that dementia is a progressive illness. Alzheimer's disease tends to start gradually and progress gradually. Illnesses such as vascular dementia tend to fluctuate. People talk about a stepwise decline. But if you look at this cartoon, you can see that the 2 yellow graphs are normal aging, and that's really in relation to whether you consider memory compared to someone else of the same age or a younger person. I always use the analogy of if I'm assessing my vision, would I compare my vision to other people of my age or to someone who is, say, 20? And so we know that memories decline, as many other things do with age. Mild cognitive impairment is the situation where people have difficulties with memory. There is some evidence that there are problems on cognitive testing, but the standard criteria of dementia, i.e. where it affects someone's ability, are not there. Mild cognitive impairment is an important condition. We know that people with the disorder are possibly 15 times more likely to develop Alzheimer's disease. But the dotted line on the graph indicates that some people with mild cognitive impairment spontaneously revert to normal, which to me means that their symptoms were due to perhaps transient emotional or physical illnesses. And then the standard symptoms of dementia are mild, moderate, and severe. In terms of the things that we've done over the years, we don't have time to go into great detail, but perhaps some of the headlines that we're doing now. There's a number of initiatives that we've done over the years in terms of dementia. I think looking at the diagnosis rate is one that's important for me. Around 2010, 2011, when the National Dementia Strategy was started, probably only about 4 in 10 people with dementia had a diagnosis. and it's now nearly 70%. So there are many people I know in the room and on the call who have contributed to that. And the issue of diagnosis for me is important because it is the entree into post-diagnostic support, which is we've seen the NHS health check. Dementia is now part of the NHS health check, and the NHS long-term plan that was published earlier this year has a lot to do with training, with support, with Dementia Connect, and looking at prevention. And all these resources here are available on the NHS England website. I'll be happy to pause there for a moment, really, as an excuse to have a glass of water. I promise it is water, it's nothing stronger, just to see if there are any specific questions. And then I can maybe just give some examples across the wellbeing pathway, which is a framework that we've used for a little while.
No, I think that's been a really useful introduction, really, and started it off really well. Thank you.
Okay. So, in terms of the kind of things that we thought were important, there were 5 things that we thought that were perhaps important in terms of looking at dementia. And we stole the tagline from the National Dementia Strategy in 2010, which was called Living Well with Dementia. And we talked about preventing well, diagnosing well, supporting well, living well, and dying well. And to me, that's quite useful because it looks at risk reduction in the very early stages, and it looks at end-of-life care, which is something that is extremely important. If we look at risk reduction, this is a slide taken from the Dementia Primer, which will be available soon. And it was really just the idea that we had was to see if we could summarise in one slide for colleagues in primary care and others what some of the important issues are. If we look at risk reduction, as I said, the suggestion is perhaps up to 1/3 of new diagnoses could be avoided if we looked largely at cardiovascular risk and the adage, what's good for your heart's good for your brain. And the risk factors there of smoking, depression, activity, I think are probably known to everyone. And there are examples there of things that we should do, from stopping smoking to advocating exercise, also to look at cognitive stimulation and things like that, as well as looking at blood pressure and weight loss. And I mentioned mild cognitive impairment. That's quite a useful group of people who might be interested, perhaps worried about memory, who might be interested to speaking openly about the opportunities for risk reduction. And as you can see, many of the things there are ones that are shared with reducing risk for heart attacks and stroke. One of the questions that I'm often asked is, well, what's the point of diagnosing dementia? You know, there's no cure, there's no treatment. What's the point of diagnosing it? And of course, when we talk about the diagnosis, when people come along to you in primary care or to me in a memory clinic, they usually have symptoms, usually of memory problems, and they're worried because of the awareness of dementia. People are generally worried about having that. We know that a proportion of people who come for assessment have often self-limiting physical or emotional illnesses, and certainly at my clinic, I spend quite a lot of time reassuring people that they don't have dementia. The situation is not uncommon that if there is, say, a family history of dementia, some might be, if you like, a bit more alert to their own symptoms. So that reassurance and the treatment of other illnesses can be important. I think the second thing about the diagnosis, there's access to post-diagnostic support. In a sense, that's a bit of a tautology, and I know in some areas there's the concept of peri-diagnostic support. That's around the time of diagnosis, so that might be the initial assessment at the memory clinic, or it might be even before that. But that support for people is the key, I think, initiative that comes from a diagnosis. It empowers patients and their carers. So we see that the people often are worried about symptoms. So to have a name, to have a care plan, to have a strategy is very important. It can prevent crises. I mentioned earlier on that dementia is a progressive condition. And so the likelihood are that there will be some crises along the way. So that support advice early on can help with that. And in the same way that we know that looking at vascular risk factors and things like cognitive stimulation have a role in reducing the risk of dementia, there's evidence in people with established disease that it can slow down the progression. So for me, and it's I put it, there is the 5 Ps as to why assessing and diagnosing dementia is a good thing. The symptoms of dementia, we all know that memory, not universally, but memory is usually the first symptom, and the kind of the history that you might get someone is repeating questions, difficulty with planning an organisation and moving things around. Very commonly, when you look back, one of the first symptoms are, if you like, emotional changes. So maybe a coarsening of affect, maybe an exaggeration of a personality trait, and that these emotional changes that are probably a reaction, conscious or subconscious, to difficulties with memory can be there as well. Remember, not all dementia is Alzheimer's disease. There are types of dementia that you might come across, probably less commonly, things like frontal lobe dementia, when there are difficulties, changes in personality, primary progressive apraxia, where there is specific praxic problems, or primary progressive aphasia with things like language. Some of the signs of dementia, as a GP, one of the things that I'm often asked by colleagues is that the person doesn't want to see you. Not infrequently, it may be a family member who comes along to express worry about someone's memory. And sometimes the person not wanting to see you, or perhaps downplaying the symptoms, is really important. And I think that is probably a reflection of people being a bit scared of the diagnosis. The family story is really important, and to be honest, I make the vast majority of the diagnosis, certainly in terms of the type of dementia, in the story from the family. We have something I call dementia torticollis, which is when you're sitting with, say, a husband and wife, and you think it might be the husband who has got dementia. If you ask the husband, it can be a simple question like, "How are you feeling?" The person will turn and look at their loved one, and to me that can often be dementia, often in the same vein as trying to downplay things, often say that things are improving, and they say, "Oh yes, I'm better, everything is fine." That's in contrast to some people with depression, who would say, "Yes, things aren't going very well and things are worse than they were." And finally, as I mentioned before, perhaps being a bit more edgy and a bit more irritable is important. There's some questions for dementia. We know that as GPs, you're incredibly busy. You have 10 minutes, so just to reassure you, you don't make a diagnosis of dementia in 10 minutes. But if there's a sense when someone's leaving the room at the end of a consultation for something else, you might ask yourself, if perhaps a carer has mentioned a concern, if you ask yourself, has the person been more forgetful in the last 12 months to the extent that it's significantly affected their daily life? And if the answer to that question is yes, then you might want to do some more testing. The mini-cog is a good example, the GP cog, or the mini ACE, the Addenbrooke's cognitive examination. Always remember for this, these are tests for cognitive impairment, not for dementia. Think of delirium, think of depression, And in primary care, you know your patients better than anyone, so you will be able to put the results into the context of the drugs that they're taking and other things that are going on in their lives. Alison, I'm not sure there. I know you've given quite a bit of thinking to some of the tests that can be done. I wonder if you want to add something now about the kind of tests that you find most helpful in primary care.
I think that the 5-minute sort of tests, the mini cog, the GP cog are useful. Obviously, we don't have the same amount of time as for a sort of longer appointment. I think if somebody scores really, really badly on even those screening tests, then that's quite can really kind of highlight. I don't know how you feel as a psychiatrist about the use of the tests in terms of if somebody scores, very low, is that strongly indicative of dementia? I think if the screening tests are kind of borderline, then obviously somebody needs to go on to have more in-depth cognitive testing. Certainly locally, we're using the mini ACE quite a bit. We also see the Montreal cognitive testing being used, but mostly locally in Cornwall, we're using the mini ACE, which I think can be done in sort of 15-20 minutes.
Yeah, I think that's a good point. The great thing about the mini cog is everyone can remember the mini cog. Ask people 3 questions, get them to draw a clock, put the numbers in and put the time to 10:10 or something like that, and then you ask them to remember the 3 words. And if they remember all 3 words, that's usually okay. If they don't remember any, that's often indicative of a problem. And if they remember 1 or 2, you use the clock drawing test as if you like a tiebreaker. But as you say, Alison, that is it needs to be put into the context of someone who is in a delirium, an elderly person who is perhaps frail, maybe has an infection. You would even a very low score might not indicate the presence of dementia, but it does indicate the presence either to think about it a bit more, or even perhaps it doesn't do any harm to repeat the test in a week, a fortnight, even a month, and take things from there.
So, Professor Burns, we just had a comment from a couple of people. I think they lost the sound to you for a second when you were explaining about dementia torticollis, which was a new term for me, but one I think I'll very, very much remember. And I just saying that's a patient turning to a relative and allowing them to answer for the patient. That's a very, I think a very useful sign. Thank you.
I would just, and it's a good point, Rob, just to reassure people, that's anecdotal. I can assure you there is no randomized controlled trial to show that that dementia collis is a test for dementia or anything. It's just something that as in primary care, you might just be aware of, as I've done. But so it's a little bit of a marker rather than a diagnostic test. But it's that awareness, Rob, that I think you've underscored is very important.
On this same note, we've had a question from Mike Jones, who may well be a paramedic. He says he's a pre-hospital provider of care, and he was just saying about a test for those healthcare providers about which one we would recommend for them to be a potential identifier for patients with cognitive impairment, so they could signpost to primary care and alert them. I presume you would probably recommend a mini cog as probably being the quickest one. Is that right, sir?
Yeah, I think that's right. However, for colleagues in the ambulance service, you're really at the sharpest end that you can imagine. And often it's the circumstances rather than the results of an individual test that would make you kind of wonder whether someone had difficulty with memory. Certainly the mini cog is one thing. The other thing is simply to engage people in conversation. Does the person know where they are? Do they know their address? But I think it's probably context is as important, not least just seeing if someone has a diagnosis of dementia. And as we all know, many people who come into hospital they can have been diagnosed as having dementia, but sometimes if it's in another part of the system, that information hasn't gone through. So certainly the mini-cog is one potential thing. But I think your experience and your judgment and that kind of feeling as to whether someone does have impairment is probably as useful as an individual test. Obviously, as part of, I know, a particular issue is the issue of capacity, and are people able to consent to go in an ambulance, and I think that's something different. But if there was one particular test, I guess it would be the mini-cog, Rob, but don't let that exclude your I was going to call it common sense, but I won't, that experience that you've had.
Speaking as a GP, I think I'd be very surprised, very impressed if a paramedic could perform such an assessment. Really, just merely a mention of that in the letters that we receive would be, I think, would be more than enough if that helps answer the paramedic.
I'm sorry to interrupt, but it's interesting. I gave a talk to some lawyers recently who were particularly interested in if someone comes to make a will, how do they know if someone has capacity? And obviously it's all around the circumstances. But I told them about the mini-cog and they thought that was extremely helpful. And as I say, the good thing is everyone can remember it. So a very good point, Rob. Thank you.
Great.
So okay. Should I just continue through the slides? And
yes, please do.
So this is really a summary of what NICE would say. The guidelines were refreshed last year, and as you can imagine, they are extremely thorough. I think for me, the important thing about NICE was that, in contrast to the guidelines 10 years before, there is an appreciation now that it doesn't need to be a specialist, and NICE defined a specialist as a neurologist, a geriatrician, or an old age psychiatrist who can give the diagnosis of dementia and even initiate treatment. That a general practitioner, a memory clinic nurse, or another professional with the skills and with the support can make that diagnosis as well. And for me, that is extremely important. And there are areas where, if you like, some of the diagnosis, I'll come to one of the tools in a minute, could be made, say, in a care home. But I think, Alison, the discussion that you and I have had recently, it's almost to give people permission. If a colleague in primary care thinks that someone has dementia, and they have they're content that all the various things that we have discussed in terms of some of the blood tests that you see here have been done, then that is entirely appropriate for them to be regarded as having a dementia. There's a couple of questions later, we'll come back to this, but this is what NICE say about dementia.
Yes, I think that if it's an obvious sort of barn door case of dementia, I think when I've been talking to colleagues in primary care, I said actually probably the receptionists know that the patients have dementia because they ring up every day for the same thing, or the person in the corner shop knows, the family know, the nurses kind of know, the whole sort of team knows. You know, it's very sort of obvious, and it's a straightforward sort of diagnosis. Then those are the patients that really could be diagnosed by a GP. You know, those sort of obvious kind of uncomplicated cases could be, you know, are perfectly suitable to be diagnosed by geriatrician, GP, and we can sort of support with that. I think also you alluded to the blood tests. We have quite a lot of confusion around these. The blood tests are there to rule out reversible causes of cognitive problems, aren't they? And it's really important they're sort of included as part of the workup, really, to sort of exclude reversible causes such as B12 deficiency, in our workup to exclude delirium and depression. Do you want me to run through all of the blood tests? There's a full blood count. You're supposed to include electrolytes, bone profile, liver profile, thyroid function, B12, folate, CRP, lipids, and a HbA1c. Is that right, Rob? Can you remember?
You know, I remember. I always have to look at it.
We're not so good, our memory assessment colleagues tell us, at remembering to put those in our referrals, really. So, but it's useful to actually, as you say, make sure that other causes of cognitive problems are excluded beforehand before making the diagnosis.
I think that's absolutely right. The one slight health warning in that, Alison, is as well that one shouldn't, in any part of medicine, be led by the blood test. So
no, that's true.
As many people who have Alzheimer's disease and a low B12 than have a dementia caused by B12 deficiency. So for sure it should be treated, and to be the same with thyroid function tests as well. And I think it's that assessment that is done in addition to the blood test, but that's a great summary of the blood tests.
I think a lot of, we do see quite commonly, I think, low folate, sort of a borderline low folate, and again, as you say, I wouldn't sort of explain that as being a sort of obvious cognitive kind of issue if somebody's got other symptoms of sort of dementia, like they go hand in hand.
The simple thing, as you say, Alison, is you treat it and then see them again in a month, 6 weeks, and you know, you get the answer.
Okay.
Okay. Now this is the colleagues from the Yorkshire and Humber Strategic Clinical Network have done a great piece of work about scanning, and it's probably one of the commoner questions that I get asked is in terms of what's the role of brain scanning in the diagnosis of dementia. Well, I think it's extremely important, but it's not necessarily for everyone in my view. Remember, a diagnosis of dementia is a clinical diagnosis, and so you can make a diagnosis of dementia without a brain scan. Many people describe whether you need a brain scan to elucidate the cause. It's Alzheimer's disease. You would see atrophy around the temporal lobe or perhaps the frontal lobe. Or if it was vascular dementia, you would see a change there. I think this a great document which is available on the website. If not, we can make sure that everyone has a copy. Is really just to put a bit of flesh on the bones about when a scan may or may not be needed. One of the things that I think is often a frustration is that people can sometimes wait many weeks for a scan, then many weeks for a report, and then many weeks to see the consultant again. And so you can have a delay of a number of weeks just, if you like, just to get a brain scan. And certainly in my practice, in many clinical situations, but not all of them, I would say, I would be honest and upfront with the patient, the family, to say, I think this is a dementia. I'd like to get a brain scan to check, but I think we can proceed with many of the things now to support you and the like, and not wait, not have the brain scan at the end. So if you like, the brain scan becomes part of the loop of the investigation and diagnosis rather than the end point. There are clearly clinical situations where you would want a brain scan if you thought there was raised intracranial pressure or if there were clinical signs. That's very different. But this is a great piece of work that's been done. Alison, I'm not sure if that's something that, from your experience, is often a question that you're asked.
Yes, I think a lot of people think that the brain scan is sort of purely to help the diagnosis. It's more about excluding other diagnoses, isn't it? Although it can help with the sort of subtyping. I think we do see quite a delay when people wait for scans, and if there's no other sort of symptoms and somebody has a good sort of supportive history and all the other features, then, like you say, it's useful to make the diagnosis more upfront so people can access the support. It is sad when the diagnostic process takes so long that people don't get the support sort of in the interim, really.
Yeah, I think that's right, and I think as you mentioned before, often people, so for example, at my memory clinic, a diagnosis can sometimes come as a shock, but not a surprise. And I think, as you say, many people, you know, when they've thought about it, they've been to see their GP, perhaps they come to a memory clinic, that they're aware that there are some difficulties. And I think, as you say, if the circumstances are right, and they are described very well in the document like this, is to be upfront and say, I think this is the diagnosis. It might change, but I don't want to delay for several months just for the sake of a brain scan. In terms of diagnosing dementia in care homes, the Diadem tool is quite a useful thing. It's one of the few apps which is sanctioned by the NHS. So if you go on, you can get an app for Diadem. And essentially it's been developed by the Yorkshire and Humber Dementia Clinical Network. A lot of thought has gone into this from colleagues, Penny, Colin Sloan and Sarah Humphrey and colleagues, really just to give the opportunity for diagnosing dementia in a care home. It goes through the steps of the kind of things that are done. Most of them, if you like, follow routine clinical practice and clinical common sense. And in a sense, it's really to emphasise that diagnosis of dementia in a care home is usually a good thing. We know the majority of people in care homes, some studies suggest 75–80% people have dementia. So having that diagnosis is important.
I think there's been a lot of discussion, I think, around that it's not always obvious at the time why it might be important for a resident in a care home to have a diagnosis. But what it does do is it gives the label for the symptoms, so that the relatives can understand and read around why their loved one's behaving as they are. It can help sort of onward advanced sort of care planning, making sure that the treatments and the plans are kind of appropriate, kind of least kind of harm. It can make sure that the care home have the care plans sort of in place, appropriate for that person. It can just help prompting and remembering when we need to consider sort of safeguarding deprivation of liberties and the Mental Capacity Act. And basically, advanced sort of care planning really. So, and also it's useful for that when the diagnosis is made and it's coded, it's there on the summary, on the patient's summary, so that other healthcare professionals, when they're visiting that person, can see that that's relevant in their history really. We need to make sure that we're using common terminology. One thing that I've seen quite a bit over the last sort of 6 months is that dementia is there, and it's sort of alluded to in the free text of a GP consultation or in a sort of a discharge summary, but actually we're sort of a little bit frightened to use the word dementia, but actually it is a standard sort of medical term, and using common terminology can help when people are visited by a different healthcare professional or when they're interfacing care, I think. So the residents in care homes, I think, are probably not appropriate really for the sort of rigorous process of our memory assessment service, which is very rigorous and can be sort of 3 appointments, some of them an hour long, probably a bit too much for our residents. So it is a really useful tool actually to make sure that residents in care homes don't miss out on a diagnosis and the support that they're sort of entitled to really. Having the diagnosis for those residents also means that they get their annual kind of review with the GP. I don't know how you feel about it, Alistair, but I think it is a really useful tool. So we're sort of rolling out and sort of advising the use of it across Cornwall. And we're sort of going to help with care homes, because I think the care homes themselves, the staff can help fill out part of the tool, can't they really? It doesn't have to be just GPs, it's quite a supportive tool really, that I think parts 1 to 3 can be helped sort of fill it out, where the care home staff can help with that.
I think you've summarised it superbly, Alison, and I think the issue is it has to be done in the correct way, with involvement of the family, and as with many things, if it's done badly, then it's not a good thing, and one would want to involve the family And in fact, that recognition that it is a dementia, which, as you say, helps onward care, advanced care planning, because we know that people with dementia in a care home, it's said that the life expectancy is the same as a lady with metastatic breast cancer. So it is something where advanced care plans, avoiding inappropriate hospital admissions are good. Something that people often say to me, oh, if a diagnosis of dementia is given to someone in a care home, they will get thrown out of the care home because the care home might not be registered for dementia. There are some pockets where you hear that can sometimes be a threat, but I've never known or seen it in colleagues that I know who are in social care say that's not a problem. And again, the label in and of itself doesn't change the needs of the person.
No, that's right. I think it might be the sort of psychological and behavioural symptoms that go with the dementia that are the concern of the care home, whether they can meet that person's needs. But those problems will be there whether they have the diagnosis or not, really. But having the diagnosis means we know what's sort of causing it. We're kind of using common sort of terminology, really, and can sort of everybody can understand what the problems are.
Yeah. But I think, as you described very well, Alison, this is about doing things and supporting people in their own homes, and a care home is the person's own home. It's their home, without having them to take them away for an MRI scan to a hospital, and, as you say, 2 or 3 appointments at the end of a long ambulance journey. That isn't good for anyone, and it's not necessary. Should I just continue on? And Dear GP is from the Health Innovation Network in South London, is another example of a similar tool. So there are a couple of things that are available. This is about looking at dementia-friendly practices. You mentioned earlier on, Alison, about the receptionist often knowing if someone forgets appointment, turns up early, turns up late. And I think the issue of dementia-friendly practices is important. This is one of the ways in which it can be achieved. iSpace itself is just, there are many ways of doing it. This is a very good example from the Thames Valley Strategic Clinical Network. And of course, it can be done in a relatively light touch way. If you get it right for dementia, you'll get it right for many older people as well. And just being aware that sometimes having a perspex glass between the person and the receptionist might not always be a good thing. When you have to go and press the computer to say you've arrived, sometimes being there to support people with dementia, but many older people as well, I think is a very good thing. And of course, it's not an additional burden. I remember a couple of years ago, I was at a meeting and there was a practice manager describing how they had developed a dementia-friendly practice. And he told the story that he'd started in this practice, and he said, you know, I'll be frank, it wasn't terribly good. We had lots of locums. We didn't have a lot of the estate wasn't very good. The records weren't very good. And then someone came and said, would you like to be a dementia-friendly practice? And I thought he was going to say, oh, it's just one thing too many. We can't have time for that. He said, we did it, and it was the best thing we did. So kind of bringing things together. And if you get it right for dementia, you get it right for older people. So a number of examples, but dementia-friendly practices are, I think, in my view, extremely important.
I think I'm going to pinch that term when I'm talking to system leaders, actually, that if you get it right for dementia, you get it right for all old people. I will quote you, though, Professor Burns.
And this is just an example of the issue of the diagnosis. It's going back a bit to the diagnosis. And this was, if people are familiar with the film Sliding Doors, the two slightly different things can happen. So this was the example that I had of Mr. Smith, who's in his late 70s, and suddenly one Saturday night he becomes agitated and distressed. He's seen by the on-call GP, seems to be a confusional state, secondary to a urinary tract infection, and he has to be admitted to hospital, and his wife in the hospital says, yes, he's clearly had a memory problem for 2 years, and in retrospect, you can see that he has a diagnosis of dementia, unfortunately sedated when he goes into hospital and goes to a care home. So that's what can happen. What could happen is that perhaps he was diagnosed by his GP a couple of years before as having dementia. He's supported by a dementia advisor, and on the Tuesday his wife noticed he's not quite himself. So his GP visited, thinks he could have a urinary tract infection because there's some symptoms he's been getting up during the night, which is to go to the toilet, which is unusual. He's treated with an antibiotic and go to hospital. So that's a scenario, just of really one of the things that for me are important in terms of diagnosis.
Professor Burns,
sorry, Rob.
That's okay. We just had a question, and could you flick it back up on the screen? It was from a student nurse actually, and she was just commenting how she gets frustrated sometimes at nurses' station with handovers because it's often handed out, XYZ patient, probable dementia, and she sometimes feels that there isn't necessarily the investigative processes going on to work out maybe why, and so obviously that leads to frustrations and uncertainties with our colleagues in secondary care. But yeah, that's a great that sliding doors example. I hope it just goes to answer the question really from this obviously diligent student nurse that ideally we can. It's a frustration for all of us, isn't it? But if we can be proactive, then that creates the crisis admissions and worse outcomes for our patients, worse outcomes for the system more broadly.
I think that's right, Rob. That's a great question, and in a sense, as you've said, Alison, the diagnosis of dementia is not one to give lightly. It's one to give carefully, and sometimes going in and perhaps putting the label on instead of a diagnosis. So a very important question, and the investigations that you've described, Alison, extremely important, rather than just having, if you like, a label. A good question, Rob. Thank you, and thanks to the colleague who asked it. So I think I'm coming to the end of the slides. So this is just, again, some of the examples that we have in the dementia primer on one page. This is what to do in terms of driving and cognitive impairment, the kind of medicines to avoid in someone with dementia that can perhaps exacerbate cognitive decline, and one of the safer ones to use. And then these are just some examples of some of the questions that I've been asked. Really, we can go through them, Alison and Rob, and just really, I think, a number of them we've addressed during the talk, but if there were any specific questions, then we could perhaps go through each of these if there's time.
So I think the mild cognitive impairment is important. It was really great when you were talking about the preventative measures for dementia, because it's quite useful rather than just somebody telling them, oh, you only have mild cognitive impairment. Actually, now we can give some advice on what they can do to sort of protect their kind of brain and sort of prevent. But what sort of follow-up should somebody have with mild cognitive impairment? What would you recommend in terms of monitoring?
I've seen a number of models. There are parts of the country where the local colleagues in general practice have said, we'll leave that to the memory clinic. So we'll ask the local memory clinic if they would do that. I think, to be fair, that's the exception. I think if I saw, say, for example, if you saw someone who was 70, who maybe had one or two vascular problems, was down a little on the on tests, and you thought they had mild cognitive impairment, or if they had been referred to a memory clinic and had come back with that diagnosis, rather than putting a specific time. I mean, I think if someone has dementia, you would see a difference in months. And so I think it would be reasonable to say, why don't you come and see me in 6 months' time and see how things are changed? The progression, of course, from mild cognitive impairment to perhaps the beginning of a dementia would be largely based on the story from the person and the story from their family. It wouldn't necessarily be based on a level on the mini ACE or the MOCA or the like. And so often when that story emerges and changes, and that's where, when I mentioned before about the family history being extremely important, listening to the family, there are more examples of repeated questioning. That would be the kind of thing. And of course, you can always say, I'll be happy to see you in 6 months or 9 months. But of course, if you're worried, come back before then. And certainly that's something for the people with mild cognitive impairment that I see. That's the kind of offer that we make. So I think it should be individualised rather than putting, is it 6 months or is it a year?
No, that's helpful. I think a lot of these patient groups sometimes do sort of drop out of follow-up. I know our memory assessment service will follow them up, but I think it's useful just if somebody sees mild cognitive impairment kind of coded in the notes from sort of, say, 12 months ago, then it's useful just to look to see, did they actually have their follow-up? Has anybody sort of followed that up, really, just to kind of flag that, not just to accept that's the diagnosis and it's not going to change over time.
Yeah, I think that's right. And of course, as I said, you would find a number of people with the diagnosis, if they were contacted, they say, oh, I'm fine. Everything's fine. Thanks very much. In retrospect, I remember at the time, there was a lot of stress and worry, but things have improved. And I see that at the clinic as well, that people, often improve on their own.
Cool. Good. I think refusal of diagnosis is an interesting topic as well. I think that crops up a lot. A lot of GPs will refer patients into the memory assessment service. They sort of go through perhaps half of the initial appointment, or perhaps the whole first appointment, but then don't really want to sort of proceed any further, or don't consent to go any further. And then so they sort of get discharged back to their sort of GP, really. So it's useful to have some advice around that, really. My personal advice would be that actually those patients we do need to kind of keep an eye on, try and keep them engaged, follow up on explore why they kind of had refusal. Is it that they don't have capacity, don't understand what their problems are, or is it actually that they're frightened around losing their driving licence? And that's something that we could explore and support them with.
I think that's a very good point, and in my experience, it's almost universally the latter. In that, these are people who probably do have a diagnosis, and it's that fear and that stigma which is important. I had the slide about driving, and yes, it is a public perception that when you get a diagnosis of dementia, you lose your license. But of course, that is not true. Someone loses the license when the driving is a danger, and that's true with many other conditions that you as GPs will know, epilepsy and things like that. So that refusal, I think I would probably see it as much as a failure of the service and the system rather than the individual. And something must have happened during the consultation. A fear was raised and was perhaps not addressed. I mean, obviously there will be some people who, that fear is too much, and they say, I can't go any further. And at the end of the day, that's absolutely their right, and one would just keep, if you like, keep watching from, if you like, from a distance. But I think it's not a thing that I see very often, although people would say, well, you see a very selected group. But I think probably managed on an individual basis. And of course, if someone is refusing because they're irritable or maybe sometimes aggressive, one always has to think of the carers as well. And I think we have a duty to make sure that the whole family are looked after.
Yeah, okay. I think we've had another question come through, which is around the what NICE guidance sort of states. That the NICE guidance state that we should be referring patients to specialist dementia diagnostic service, such as a memory clinic. I think that's the main point. Is there any more to the question? I think
so it's from Rebecca Reed, a psychologist who I've worked with in the past, actually. Hi, Rebecca. So it was just about diagnosis from a GP point of view, saying about NICE clearly state that we should refer to a secondary service once organic causes have been ruled out, which is what we covered before. But in terms of obviously clinical assessment and the blood testing and common sense, as you say.
Yeah, and it says that she's concerned because actually the NICE guidance don't suggest that GPs should diagnose.
Well, if you look at it, it doesn't say GPs should diagnose. What it says very clearly is that GPs are able to diagnose if they feel, in fact, it doesn't go quite as far as to say anyone can give a diagnosis of dementia if they have the right skills and training and support. So there's no suggestion in the NICE guidelines or anything of people being asked to do something that they don't feel confident in doing. What this is giving people permission to do it if they feel confident and they have the right skill set. The issue of referral is that's really a kind of the old division between primary and secondary care, and we use the example of a care home, Allison, where I don't think, and I think you would agree, it's not appropriate for someone to be taken from the care home to spend a lot of time at secondary care. But of course, that referral doesn't necessarily have to be someone geographically going to a different place. That can very often be given close to home, and I'm sure that wasn't what NICE had in mind when the suggestion was there.
Thank you. Yes, so the final comment was that the NICE guidance aren't perhaps as helpful, that there's some aspects to them that aren't necessarily kind of clear or practical. We don't want people missing out on a diagnosis. And
remember, they are guidelines, and yes. If we feel that there are things that we do that are best practice, so for example, I've never heard anyone say to me, "Oh, I'd rather wait another 3 months for the diagnosis as long as it's in line with NICE guidelines." I'm being deliberately flippant and provocative, but I think that where the circumstances are right, we should use them as guidelines and not a reason to stick to a rigid system.
Thank you.
There's another question in, so which I'll just field for now. There's a question from Alexa, a GP trainee that we know, and she's just asking about resources for end-of-life care in dementia. I know that that's going to be the focus of a specific webinar in this series coming up. So I think that's going to be dealt with in its entirety.
Is that going to be a cliffhanger? You have to tune into future webinars.
A bit of an EastEnders drum roll for that one, Alexa.
Unless Alistair Burns, you've got anything kind of a quick line.
I'm certainly not going to spoil next webinar. In fact, if you could send me the details, I'd like to tune in myself.
Okay, thank you. Okay, so I think we've covered quite a lot really. I think the best thing is kind of seeing the benefit in the diagnosis, which often isn't always sort of obvious really. And I think you gave a really good summary of that at the beginning, Alistair. I think that one of the key things for me is that it empowers a person. This is an illness or a long-term condition whereby the person might lose capacity. So diagnosing it early and letting them be able to have a say in their future care, it is really empowering and really important. There are other kind of hidden benefits, such as somebody's got a diagnosis, we can signpost them to take part in research. taking part in research makes people feel valued. I think one of the difficult things with living with dementia is sort of the effects on the person's life. So anything that can make them feel valued is really important. I think sometimes we don't realise that actually that can help with benefits, council tax reduction, and lots of hidden sort of benefits really that aren't always obvious. But I think it is important to note that a diagnosis of dementia is a big diagnosis. It should be delivered with no less sensitivity than a cancer diagnosis, really. But we really shouldn't treat dementia any different to sort of the other long-term conditions. And it's really important that we put it sort of on par with the other conditions and also with the others. It is the leading cause of death. So I think it's up there as important as cancer. And we really wouldn't leave somebody with cancer without really explaining the diagnosis, signposting them to support. And so we really do need to kind of see dementia as sort of one of our long-term conditions and really important. If we've got a condition that is our leading underlying cause of death and it's a condition that people fear the most, then to me it is a really important healthcare condition that we should be focusing on really and learning about how we can support people best.
I think you've described that exceptionally well, and the soundbite that goes with that is that we want a diagnosis of dementia to open doors and not close doors.
Yeah. So we've had a question around, is there is there a research project for the young patients with a diagnosis of dementia? I think locally not, but Professor Burns, you're more kind of aware of kind of national research.
Yes, there's a great project run by my colleagues Janet Carter out of UCL, the Angela Project, and there is the Young Onset Dementia Network that has lots of information, and many of the genetic studies involve younger people with dementia who are probably slightly more likely to have a familial type. So there's lots of projects that are going out specifically, and a very important group to draw out the people with young onset dementia. And just to be clear as well, when we talked about the diagnosis, Alison, in a sense, as you describe it, it's where, you know, the diagnosis is, how can I put it, is relatively straightforward. Someone of 55 who perhaps has particular symptoms, that wouldn't be the type of person that I think it would be appropriate to expect a GP to make. That's the kind of situation where you need some input from a memory clinic, or, you know, as I do myself, refer to a specialist tertiary clinic for the diagnosis of dementia. So certainly the people with young onset dementia, an important area, but the Young Onset Dementia Network has got a lot of information about that. So if the colleague wanted to get information there, it's certainly available.
Okay, no, that's great. And we've had another question. Somebody really keen, thank you to our audience. Somebody's asked if they, by registering, will they be automatically sent the dates for the rest of the webinar? So my cliffhanger must have worked. So yeah,
yeah, it's good. So thank you for your enthusiasm, certainly. So I'm sort of very keen to receive feedback for this event. So you'll be sent out an email with some requests for feedback. Once you respond to that, then we'll send out certificates of attendance for your portfolios, and attached to those certificates we'll have our the next link for the next webinar. But we've already got a date in the diary for the 31st of October. Not that I think anything else important is happening on that day.
Okay, so Professor Burns, if you'd like to do a little summary for us, I think.
Yeah, so I think thank you very much for the opportunity. The only thing is that I've missed out on a trip to Kernow by doing it on the webinar. But, you know, it's been a great opportunity, and I think it's about raising awareness of dementia. It's about getting the diagnosis right in the right setting. But as I say, it's getting that post-diagnostic support in. And when I visited Kernow, I was overwhelmed by the enthusiasm in the room. And of course, it's not just us in the NHS, it's not just us in primary care or secondary care. It's a challenge and an opportunity for the whole of the system. That's health and social care. It's the voluntary sector. It's all clinicians, whatever their background. So I think the excitement that I saw when I was in Kernow, and the interest in the room, Allison, you and your colleagues, and Rob's interest in taking this forward is really very, very much appreciated, and it's great stuff that you're doing.
Thank you.
Well, sir, thank you very much for your time. It's been a real flagship thing to start. So thank you for very much indeed. And we're very pleased with how this has gone so far today. And we've dragged some participants along with us throughout. So thank you
really grateful
very much. Well done, everyone, for joining and being part of it. And as I said, next one will be on the 31st of October. We'll send details out once we've received your feedback. So we'll just close.
Yeah, so the topic for the next one is based a little bit more around sort of the diagnostic process, around the sort of 3 Ds that need to be kind of excluded before you make a diagnosis. So it'll be based around identifying and managing delirium, identifying and managing depression in the elderly, and also comments around sort of drugs and alcohol, really, to sort of help the diagnostic process. And future webinars will include how we can support people to live well in our county with dementia. Also, there'll be a webinar on some of the legal issues, the Mental Capacity Act, power of attorney, all sort of legal issues around dementia. And also we'll be joined by colleagues from the hospice who will be helping us sort of look at treatment escalation planning and end-of-life care, advanced care planning for patients with dementia. So hoping that we've got another 4 sort of webinars to run.
Yeah,
so thank you.
Following a chronological type issues as they present to us as clinicians. So thank you all very much for your time and attendance, and I think we'll draw the webinar to a close there. So thank you very much.
Bye-bye.
Thank you, sir. Take care. Bye-bye.
Thank you. Bye-bye.
Thank you.